Thank you, Chairman. I'm Dr. Jung from Korea University. Today, I would like to talk about for monitoring strategy for anticoagulation in ECMO. As you all know well, you should use the heparin during ECMO because of thrombus formation. I will introduce the recent trend of monitoring and suggest the protocol. I have no disclosure. Unfractionated heparin management. Traditionally, ACT has been used basic monitoring for heparin anticoagulation. We usually inject heparin from 50 to 100 units per kilogram before cannulation. Maintenance dose is from 10 to 30 units per kilogram per hour. Target range of anticoagulation monitoring were introduced in Red Book. ACT is from 180 to 220. APTT is from 50 to 90 seconds. And the anti-10A level is from 0.2 to 0.6 per milliliter. ACT means activated clotting time, measuring intrinsic and common pathway of whole blood with all cellular elements included platelet. ACT can be done by POC and low cost, so we easily check always and every day. However, accuracy of ACT was easily altered by coagulopathy, platelet dysfunction, hemodilution, and hypothermia, etc. Activate partial thromboplastin time, we call APTT, is one of the most commonly used anticoagulation assays, which measures the clotting time from the time of activation of factor 12 to the formation of stable fibrin clot. APTT from 50 to 80 seconds is 1.5 to 2.5 times of normal range, and correlated the heparin level of 0.2 to 0.4 unit per milliliter. APTT is more reliable than ACT at relating low and then moderate levels of anticoagulation. POC test is not available yet, but improving now. Thromboelastography, we call TAP, and thromboelastometry, we call ROTEM. This method measures of clotting kinetics of whole blood. This measures the viscoelastic properties of a hemostasis process of functionality. The end result being the hemostatic clot. Also, it's real-time measurement of clot strength over time. The rate and strength and stability of clot formation will determine a patient risk of coagulopathy, bleeding, or thrombosis. As you can see in the lower figure, schematic of viscoelastic testing with the specimen of whole blood in a cup. This cup heated to 37 degrees of Celsius. In case of the tap, the cup oscillates with the pin remain stationary. Whereas with rotational thromboelastometry, we call ROTEM, the pin oscillating and the cup remains stationary. Measurement of pin synchronization with the cup reflects the stage of clot formation. This is a graph of the tag And then in here, R, the value of R and MA and LY30 is important. R means a reaction time. So it takes time to inject the cowline that triggers the intrinsic pathway and then to form a clot for the first time. This is to measure the enzymatic anticoagulation through the intrinsic pathway. MA means maximum amplitude. This is the maximal clot strength. It reflects the combined function of fibrinogen and platelet. Low MA in a bleeding patient may suggest benefit from platelet and or fibrinogen transfusion. LY30 means reflects the degrees of clot breakdown over 30 minutes. So you have to wait 30 minutes after finish the R processing. TAC is most helpful in complex coagulopathies, where multiple coagulation abnormality are occurring simultaneously, such as liver cirrhosis and DIC, including trauma-induced coagulopathy. And then another complex intraoperative coagulopathy, such as cardiothoracic surgery and then liver transplantation and ECMO. The disadvantage of TAC cannot monitor the effect of the antiplatelet function effect, like aspirin and clopidogrel, and then cannot check the. Also, it is not possible to discern the clotting disorder caused by other clotting disease, such as von Willebrand disease, and then antithrombin, protein C, protein S, or factor V Leiden deficiencies. Also, because of the test is conducted at 37 degrees of Celsius, it cannot detect the clotting disability by hypothermia. The advantage of TAC testing is that can be done very fast, and then it can evaluate the interaction of coagulation factors, endogenous anticoagulant, and cellular element. Also, it can evaluate the platelet function, not only count, and it can evaluate of the thrombolysis, which is not measurable using conventional coagulation assay. This repeat testing of the effect of heparin on anticoagulation, so can determine the effect of heparin on clotting. Last one is the anti-factor 10A assay. The anti-factor 10A or anti-10A assay is the functional assay that facilitates the measurement of antithrombin. Antithrombin catalyzed inhibition of factor 10A by unfractionated heparin and direct inhibition of factor 10A by low molecular heparin. The anti-10A assay can also be used to guide the determination of therapeutic APTT ranges in the clinical management of unfractionated heparin. This is basics of anti-10A assay. Technochrome anti-10A is a system of a reagent for the chromogenic determination of direct and indirect 10A inhibitors in human citrate plasma. The assay is based on the inhibition of activate factor 10 by antithrombin in the presence of heparin as a measure. as measured by chromogenic factor 10A substrate. At first, binding complex of heparin and thrombin with factor 10A is made, and then residual non-inhibited factor 10A cleaves the chromogenic substrate. This assay leads optically the released chromophore. Amount of chromophore is inversely proportional to the heparin concentration. This international survey is a current practice of monitoring heparin on ECMO. About 70% of centers in the world is using anti-10A and ACT combination. And the second most common answer is to monitor anti-10A, ACT, and APTT together. Only about 15% of centers use the TAG or ROTEM. In terms of anti-10A influenced factors, that means what could affect or alter anti-10A level. Anti-10A level firstly increase in the presence of a hyper TG above 360 mg per deciliter. And in the presence of the oral factor 10A inhibitors such as apixaban and rivaroxaban, etc. Whereas in the case of total bilirubin level above 6.6, it was firstly low. Also, when any substrate that could interfere with light absorption of 405 nanometer is present, the level is measured firstly low. This is a paper that analyzed correlation and the heparin dose with laboratory APTT, POC APTT, and ACT. For about 4 years, data were analyzed by 172 neonate and pediatric patients. As a result, ACT had no correlation with the heparin dose. APTT had a weak correlation with the heparin dose. And the cardiac ECMO had better correlation than respiratory ECMO. ACT is not an accurate monitoring tool for heparin management in pediatric ECMO. The POC and APTT correlated well with the clinical laboratory APTT, but cannot be substituted for the clinical laboratory APTT value. Management of pediatric ECMO with the clinical laboratory APTT can reduce bleeding complications, which are associated with increase in mortality. This paper recently published in KSCCM. They analyzed associations between bleeding events, APTT, and anti-10A and TAG variables. 63% of our patients had bleeding events. It showed TAG variables were strongest predictor of bleeding. In case of maximum amplitude below 55 millimeter and then reaction time over 12.9 minutes, it showed highest risk of bleeding. And then in case of maximum amplitude over 55 millimeter and then fibrinogen over the 345 milligram per deciliter, it shows lowest risk of bleeding. This paper also performing for infant and children. The result of shows ACT too imprecise to use for ECS, and anti-10A activity was most specific and sensitive measure of heparin anticoagulation. Suggests the APTT is the best choice when anti-10A is not available or hemorrhages, the patient have hemorrhages or hyperbilirubinemia. This paper showed anti-10A compared to APTT achieves therapeutic anticoagulation more rapidly. You can see in this graph, in the middle is anti-10A is a more fast, rapidly reach to therapeutic anticoagulation level, maintain the value within the goal range for a long time, and then require fewer adjustment and in doses and repeated test. This meta-analysis, which includes the previous study, published in 2012, and it showed a similar result. This meta-analysis showed anti-10A has the strongest correlation with the heparin dose in children undergoing ECMO. It's the same result with the previous papers. This another meta-analysis which published recently in this year, last year. As you can see, overall anti-10A based anticoagulation strategy was associated with fewer bleeding in left graph, and then decreased mortality rate in the right graph without any increased thrombotic events. Issues associated with the heparin monitoring test. This table summarizes the issues about the monitoring strategy. In case of ACT, first prolongation by thrombocytopenia, factor deficiency, and hypofibrinogenemia and hypothermia. APTT generally accept means of titration heparin coagulation. Recently, many of center is mainly check the APTT for heparin level check in Korea. Anti-10A is I mentioned many times in this presentation. It is a very good association with the heparin dose. Some center already use this one, my center also, and so I recommend it. This assay is a very good method for educate proper heparin level check in ECMO patient. But anti-10A is firstly low in presence of plasma-free hemoglobin, like hemolysis and hyperbilirubinemia. TAC and LOTEM is very good sometimes, but many of center have no this device. But some cases, in case of trauma-induced coagulopathy and then DIC, we can use this device for patient, and then we can get a very good result. This study was performed by using anti-10A based protocol and analyzed the clinical outcomes before protocol period and after. Pre-protocol means just target anticoagulation is ACT level, 200 to 220 seconds. Post-protocol means target of anticoagulation is anti-10A level, 0.3 to 0.7 minute per milliliter. As a result, the bleeding of cannula site and requiring surgical correction decreased significantly. But the oxygenator clot also increased. In addition, the post-protocol group showed a significant decrease of blood transfusion volume. This study also relates to the effects of an anticoagulation protocol. The protocol is the APTT was checked every 6 hours and then checked twice daily. Therapeutic goals were defined as APTT of 60 to 80 seconds, TAC reaction time from 2 to 4 times of baseline with no fibrinolysis. Anti-10A level of 0.3 to 0.7 unit per milliliter, and antithrombin level over the 50%. The result showed a significantly lower retroperitoneal bleeding and mortality on ECMO. However, no differences in thrombosis. Summary. Bleeding and thrombotic complications have significantly impact on clinical outcomes. Clinical therapeutic approach to ECLS anticoagulation and monitoring may no longer be adequate. Novel options, including APTT, TAC, LOTEM, and anti-10A assay for monitoring of ECLS anticoagulation are available now. The best test is the one you can use at your center, but I recommend to keep target anti-10A levels and evaluate the patient clinically for bleeding or ECMO membrane clotting. TAG is also useful or urgent. Each center should prepare and apply the anticoagulation monitoring protocol for heparin. It will be decreased bleeding, complication, and transfusion without increasing thrombosis. Thank you for attention.